Right. Yeah. Right. So the goal of this conversation, the goal of this conversation is to talk about design thinking, and not just design thinking, evidence-based design thinking. To understand your process of thinking about, design specifically healthcare solutions, real-world healthcare solutions, and how you bring the two together. Design thinking, empathy, thinking about the patient, whoever the stakeholder is, talking to them and getting their preferences, but underlying all this with evidence. And I want to talk through this with maybe some of the projects you've talked about. I know that you said you're part of the SickKids Horizon project. You're helping design the ICU. And so that has, implications. Design of ICU has implications for things like infection control. Where do you put the hand wash station? Where do you put the gowns, the trash bin in the anteroom for isolation purposes? So these are things that are design solutions that a person might not think about on a regular basis, but these things have implications for the quality of work. Where do you put the rooms in relation to the nursing stations, in relation to the supply rooms? So I would like to understand your process. So maybe just start talking about, what design thinking means.
Yeah, absolutely. It's a great question. I think it's a perfect way to start. In my mind, design thinking really is a methodology, and it is a specific methodology to drive innovation. And the key of design thinking is that, one, it must be human-centered, meaning it must focus on the needs of people. And it must also involve a creative mindset. And so you need to go into it with the idea that you don't know the answer yet. You need to go into it with the idea, ultimately, that you may only develop a temporary solution for the people you're designing for right now, but that ultimately, over time, people's change, needs change. And with that, the design thinking process must be fluid enough to react to that as well, too.
Mm-hmm.
Two main things with design thinking. And from there are multiple different schools and methodologies. There's two very classic ones of how you actually go about this process. And I'm happy to speak about that, which I think is probably helpful to frame kind of the rest of our conversation.
Sure. Maybe talk about the schools.
Yeah, exactly. So the first kind of process for design thinking was actually developed by the Stanford Design School. It's called the D School. And it really is a 5-step process that starts with what we say empathy. And empathy really is for your end user or the person you are designing for. So this is how you pull in that human-centered component within this. To obtain empathy and to really understand it, then what the design thinking process will involve are things like interviews with end users. It will involve observations in real world. And it really is trying to get at both the physical needs, the emotional needs of the end user. When I say end user, I'm using this, it's humans at the end of it, but your end user may be a group of humans. It may be, a system, a hospital itself. That could be your end user for it. It also could be an individual patient or healthcare worker when we're talking about the healthcare context. So what you start with, and you start with a lot of time to empathize and really asking about whatever the problem is that you've been challenged with, because the key component of design thinking is that you have to go with the mindset that you may not truly understand the exact problem at the very beginning. And oftentimes what is brought to a group of designers or brought to a group of leaders or anyone working in the field may be a downstream effect of a more key core problem. And instead of trying to just jump in and come up with a solution that's going to fix a downstream effect, you are actually better off going back and truly understanding your problem and maybe potentially solving the key problem as opposed to a downstream effect. And so this is the true idea. So you start with empathy. You start with gathering as much possible information as you can, because the next step then is what we call define. And it really is just what it sounds like. It's defining the actual problem you think you're solving. It's done in a very classic way, and it's done with what we call a how might we statement. So how might we, design, implement, develop, change, etc. And that is going to be focused then all based on what you learned from your empathetic interviews with your end users.
So,
it's at that. Yeah, go ahead.
Yeah. Keep going. That's fine.
I was going to say, at that point, then you start the ideation phase, and you start where you actually think about what designers do, right? They come up with the new ideas, they blow it up, they come up with very creative ideas. And at this point, really brainstorming is key. You want as many possible ideas as you possibly can have. Nothing too big, nothing too small. There's very classic, and it is important to have both a combination of people who are design trained, people who are within the industry, so within healthcare, with people that you are designing for. And then oftentimes it can be helpful to have people potentially in other related industries that are all working together on this and that are what we say co-designing, because that's a key principle of this phase is you want to co-ideate and co-design your potential solutions. Things that I think of when I'm kind of driving it, as I say, if I had, if money was no object and I had, $1 billion to solve the problem, what would my solution be? If I had $1 to solve my problem, what would the solution be? If I have 5 years to figure it out, what could we do? If I have 5 minutes and need a solution, these are the kind of idea generation things that you will use. And then this is where you classically will see, if you Google design thinking, you will probably find a photo of a whiteboard that has a lot of sticky notes on it. Designers love whiteboards. They love sticky notes. And the idea is if any possible idea you put on a sticky note, you slap it on the board. And then after that, you really start grouping and you try to have patterns emerge out of those groupings. And with that, ultimately, your next step then becomes, from your patterns that emerge, you figure out one specific prototype. Prototypes should never be perfect. They should always be very rough, low fidelity, and very, very quick solutions that you just want to get to testing. You want to test it. Once you have your prototype, the idea that you think will solve your defined solution, you then go back and test. And you test it with your end users is the key part. So you bring them back in, you show them your prototype, you have them work with it, you have them feel it. If it's a space, you have them walk, like you try to do visual representations potentially, even mock-up spaces, you have them walk through it, and you get as much feedback as you can. You at this point should embrace failure, because the more you do not expect it to be perfect, and you want as harsh of a critique as you can get, because that's going to define your next step. Once you've tested it, you then may need to go back, and maybe your users will say, yeah, you're really close. So what you'll do is go back to your prototype. But they may actually say, this just isn't working. So maybe you have to go back to ideation and figure out what was on that grouping on those boards, what were other potential ideas to reprototype. You also may get to the point where you realize you don't understand the actual problem and you actually are solving something totally different. And from that part, you go back to your empathetic interviews. So what I'm trying to convey here is you test and then you go back. Ultimately, and then you'll move through the process again to where you retest, and ultimately you'll get to something where you think, okay, this is good enough, this is the best we can do, we're going to implement. That's where then you're going to go and obviously put it into practice. But the key part, as I said at the very beginning from design thinking, is you need to understand that this really is at best a temporary solution, and you have something you think will work now, but the creative mindset should always be questioning, is this what is going to work? Have people changed? Have our needs changed over time? And then how can that be adaptable? That's a lot of words there, and that's but that's the most kind of classic framework for design thinking, and I think that's the one that in my mind is probably most helpful. And I'll pause there for a sec before I can very briefly talk about the other one from the Design Council.
No, that's fine. Just to address this a little bit, from what I'm hearing is that you don't know the problem, you don't know the answers, and you have to talk to people and get that feedback and get harsh criticism, help refine your definition of the problem. I want to know if there's any space for a visionary creator, a visionary leader who because sometimes people say that people don't know the problems they actually have until you design a solution for it. The classic example is a microwave. Before people ever had a microwave, they would never have considered that they needed a microwave. Or if you had asked people who were driving horses what they want, they might have said a faster horse, and they might never have considered the possibility of an automobile or of a car. And even the first prototypes of a car might not have even seemed as what they want, because they couldn't have visualized the potential for the car to change the world. So is there any space in this framework for a visionary leader who is confident and convicted about a problem and is looking to solve it regardless of the opposition?
Oh, I think so. I think absolutely. I think what I will actually say is I think if you actually look at the process that many visionary leaders have, they follow a very interesting pathway that a lot of this have a lot of the principles we're already talking about, right? So the difference and oftentimes actually design thinking really is just a framework to try to operationalize what visionaries are able to, what we say visionaries are able to do at the time. So think back to microwave, right? What, at some point you would have to have a vision, an idea that, this actually can be used, right, to heat food, that this is a side effect that you can do it. But without the actual understanding of, our current process of heating food, right, is slow and is labor intensive, or maybe we're using coal stoves, maybe we're using gas stoves, whatever we're using at that time, you have to have the idea of, is there a way to do this better? This is a lot of the same type of processes with the visionary leader. Now, I do believe also that there is something to be said for you don't know what's possible until someone shows it to you, right? And so until you actually get out there and test it and use it. But at the same point, a visionary leader is only as good and have this idea until it's tested, right? And that's also the other kind of big part of this. There's a lot of visionary stuff that has completely failed the testing phase.
Sure.
And so I actually think this is a way of operationalizing probably what a lot of classic innovators and visionary leaders are actually doing naturally.
And the second thing I just want to point out, you talked about how it's a cyclical process. You build something, you take it back for feedback, you build something. Usually, back in the day, Facebook was the classic example. Their motto was move fast and break things, where you just keep on building lots of products and you're not sure which one will stick, but you're just building as many as possible and hoping that one will stick. I know, how would this be different from this cyclical process? And is there any space for one or the other?
It's very, it's very complimentary. What I will say, and it's actually really nice. I'm going to answer that question in a bit of a roundabout way, because it's actually a really nice lead into the other kind of big methodology for design thinking. It's called the double diamond. And it was developed by the Design Council, which is a big international standardized forum for design. And so what this is involved with is involved the ideas of divergent and convergent ideas in a double diamond pattern. So you come up with the idea that you start with discovery, and you start with, we have something we want to try to solve, and you, at the same point, it's the same type of thing I was talking about before. You interview your end users, you observe them, and you try to diverge it out. But maybe your end users at the time, maybe what you are actually doing is you're trying, like as you said for Facebook, they had a million different ideas, different potential things that this could do. And so they fully they blew it up. They opened up as many possible ideas as they could. Once you have that, you then go back and converge, right? You come back to what you say defining of what we're going to actually try to do and try to put forward. At that point, it's the same type of thing that the previous one says, you define your question. The same next thing is that you develop. And I think that's where a lot of times with the innovative cycle, we just see the develop rapid ideas. But what's different about this one is they ultimately converge back onto an idea or two to deliver, but usually the double diamond will do multiple prototypes. And then what they do is they throw those out to a group of users to say what works, what sticks, and what doesn't. And so as opposed to the classic Stanford, design school one that really wants you to do one prototype, go back and kind of reassess, the divergent convergent ones believes more that you put out a bunch of ideas, you get them in front of your users, and what sticks, you then pick those, and you see if you can further refine those into one single prototype in the end. So I think it's also another way to do it, and I think the idea is it fits into the same type of thing. People don't know what is out there, what they have, until you show it to them, right? And so you put it out there in front of your end users, you see what concepts stick, and then I think ultimately you go back and you reframe that, you re-prototype that to figure out if there's a way you can converge those ideas back into your one solution, if that makes sense.
Yeah. So I think that's one thing that makes healthcare different from every other industry where these ideas are applied, is that healthcare is supposed to work on a base of evidence that's really different from things like patient preference. So you can talk to users, patient preference, stakeholder preference can have implications for compliance or quality, the quality to perceive in the care. But there has to be some kind of scientific basis for a solution that people like. that doesn't satisfy some medical, question. It's not doesn't fit in healthcare in the way that it might just fit in the world. If you're with Amazon and you're just trying to deliver something or get people to pay you money, that's different. So how does evidence then? This time not just evidence of what people like, but scientific evidence then fit into this paradigm as a kind of limiting factor.
Oh, I love this question. This is where it really gets me riled and gets me going. So I think you alluded to what I think is one of the crux of problems we have with driving change and innovation in healthcare. And the idea is we must be evidence based, as you clearly say, and a lot of our work, especially within academic medicine, focuses on research and focuses on trials and informing the evidence. The problem is, if you actually look at it in the end, the amount, even if you have these quite positive trials actually get implemented, is a small fraction, and a small fraction that actually makes it to the bedside, as sad as it is. I don't have an exact quote, but I've read it multiple times before, and it's been estimated that it is a small fraction of actually, if you poll multiple hospitals and look at institutional practices, even a pretty strong randomized controlled trial takes a really long time to stick. And I think the question is why, and you alluded to it really, really well, that there are a lot more factors that go into how we practice medicine than just what the research shows. The evidence is a big portion of it, but you're also dealing with people, and you're also dealing with, when I say people, I mean, patients. You're dealing with healthcare providers and their own background training. You're dealing with cultures and systems and organizations. Every hospital will have an organizational culture of the way we do it, the way that the University of Toronto, the way that, the University of Michigan does it, our way. And I think a lot of this comes into what you say. Unless people like it, it can be really hard to get it to stick. Mm-hmm. And so, there's been multiple efforts, and once you have research, once you have an idea of what the evidence is going to be, then usually the way this classically has been done is through quality improvement, right? Mm-hmm. Quality improvement and safety science. Mm-hmm. To actually work on implementing these. But the problem with that, you can do beautiful QI work. You can show that with this new intervention, we have decreased, we have changed this practice, we have this sort of outcome. But the problem is getting it to stick. And the problem is getting this to be something that stays and changes the actual overall practice. And I think the part that really is missing is, regardless of how much evidence we have that we should do it, if people don't want to do it, if it's not the actual natural practice, then it's not going to happen. And I really think this is actually where design can come into play. And I think the evidence portion of it comes into, when you're doing your empathy interviews and you're trying to figure out, why, for instance, why, how might we, implement, I think off the top of my head, hand washing stations to decrease infection, in the ICU. Okay, so that is your question. You have evidence that you need, and evidence can probably tell you how many you need per patient and how far away they should be to implement it. But the question then is going to be, from a design standpoint, if that is actually your problem, then you're going to have to figure out within your actual space, where are you going to put the stations? How are they going to look? What naturally makes the most sense? And it's that part that I think design can actually answer. I think design can answer the parts that really rely on the humanism portion of it and the empathy portion of it, and it's not just the data and the science. And I think that's where it comes in. If we relied, the other thing I'm going to say is, in all reality, and what feels uncomfortable is design doesn't always involve evidence-based medicine, right? And design doesn't always involve randomized controlled trials. And it's because it's really just going to be impractical, we could do a randomized controlled trial of what wall color, to paint the hospital room that maybe decreases delirium or makes patients more calm or makes them go to, sleep easier. And maybe that is worthwhile. But the reality is we actually have a lot of the data from, the design literature that are on color theory already. And so I think the crux of this and what feels really uncomfortable is, in medicine, we do exist with, and we have to focus on the evidence of all of this. But the reality is there also are some very tried and true principles of design that I think can make it in just as easily. And so I'm happy to talk more about evidence-based design. That is kind of one of my main focuses. And in SickKids is in a really nice, where I work now is in a really nice position because we are working on designing a new hospital, and it is incorporating as much evidence as we can.
Yeah.
But I'm happy to talk about that if you want to hear about that. But
so I'll really love to hear about your process of your design in SickKids, the Horizon project. What exactly are you doing, to when it comes to design thinking?
Absolutely. So it is the exact same process in general that we kind of described before. And so the work that I'm doing and working with is focused on the intensive care unit, the physical space of the intensive care unit, which is where I work. I work specifically in the cardiac ICU at SickKids, but this work is really applying also to the general pediatric intensive care unit as well. Mm-hmm. For all the medical surgical patients. And so the way this actually works in all practicality is kind of what you exactly think. Now, the very interesting part of this is, existing as a designer within the space, I also am existing as a designer, but also an end user and a healthcare worker who will physically work in that space as well too. And so I think it involves a unique perspective, but it's exactly what you would assume. So we start out with really trying to understand the needs of the space, the needs of the end users. And so the tricky part about all this is what I'm going to say is ultimately, hospital, rooms are expensive. ICU rooms are some of the most expensive that we have. There are national standards of a minimum amount that you get. And ultimately, the way most of this actually works is your funding. So whether, it's Canada and it ultimately is the Canadian government and Health Canada, or whether, it's in the US and it is your healthcare system, is ultimately going to decide how much money you actually get. And so I think the goal of this evidence-based design is really, if you can put some evidence behind it's going to make a difference for a patient, you might have a chance of actually getting this built. But the way we actually do it, I diverged a little there, but the way we actually do this is we bring in the end users. So we bring in the healthcare workers, the physicians, the nurses, the respiratory therapists, the nutritionists, all the people there. We actually bring in patients, we bring in families and as well. And then we bring in architects and we bring in designers, and we bring in people who are actually very, very, skilled at actually, doing hospital needs assessments. And you do end user interviews. And so they do very extensive end user interviews for, what does your ideal room look like? What do you need in your space to perform the ICU care? They do observations. So they come in and take a lot of videos. They observe everything that you do. And the real goal is to not only see what is happening, how you set up your space, but really to make a functional assessment. So what are the person doing at the time, and what about the space allows them to do that? Because you have to gather all this information together, and then you do these really in-depth end user interviews to come up with what exactly are your needs you need to put together. It then becomes, you essentially are defining your at this point, your problem in your defining phase really is understanding exactly the needs that you need to have within the confines of what your resource is. So how much, how much ultimately money you have, or how much, we know in general the physical space has to be constrained to this size. So how are we going to design it? It's then the architects and the designers that will come up with a prototype. And usually these are small sketches that they will then, oftentimes more and more, they're putting into specific software that will allow a virtual walkthrough, kind of video wise, to see what in general do you think. Feedback will then happen. Then they'll go back and they'll reiterate it. And ultimately what we've gotten to now is we've actually gotten to doing cardboard mock-ups. So we go to large warehouses, we mock up the space with cardboard, and literally to the exact dimensions. You walk through what potentially a proposal for your ICU is going to be. The key focus on this usually is connection between the spaces as well, because this is the chance you really get to see what are your sight lines like, what are how can you move within the room. And then what we do is, to test it, we actually give people a task, because you really want to get to a functional assessment. So oftentimes it might be, let's get a patient, into the ICU. So, how are we going to, from the elevators, can we make all the corners? Well, what if they had a vent as well? So we pull the actual equipment in the room. So it's doing it as high fidelity as you can in terms of, we use the exact stretchers, the exact equipment. with the exact people, seeing if you can move within that space with the cardboard. And when you can't, then at that time, it's all the designers and the architects that are actually physically changing the cardboard in that moment to see what kind of space you need. I think that's really how, if you're looking at a physical space, that's generally how we actually go through the design thinking process, especially if you're talking from a prospective standpoint. The retrospective work that comes in will look at, if we look at these spaces that we have built, you pick whatever your end goal is. So, maybe it's ICU delirium. And so you look and you see, is there a pattern for, specific patient rooms or specific hospitals that have less delirium than others? And then you go in and you actually take pretty detailed measurements to figure out potentially, is there something about the space itself? That's the other way that evidence-based design happens. It's the more kind of classic way in many ways as well. But we're getting to the point where oftentimes a lot of the questions really need to be done from more of a prospective standpoint. And so it's kind of through this modeling that we're actually getting these answers.
So when I listen to you, you talked a lot about the functionality of the space.
Yep.
Is there any place for aesthetics? Because one big thing for me is aesthetics. I often say that apart from the pay, the work-life balance and passion, I want to work in a nice space. And it's a big deal for me when I'm choosing a place to work. And hospitals don't seem to, put a lot of thought into aesthetics. So, design thinking and aesthetics, how would you merge the two?
Absolutely. I think this is a key question. I said a long time ago, I don't think any patient or any healthcare worker felt any better about their day in the room looking at salmon colored walls, that hospitals tend to love, or those kind of puke green walls that we used to always use as well too. If you look at the evidence-based design literature, there's actually pretty strong evidence that things like exposure to views in natural light do decrease things like the amount of pain medication that patients use. They do overall improve healthcare worker satisfaction and have less associated burnout in hospitals that use more natural light as well. Things like a lot of studies have been done on the maximum amount of light and the sources of light, whether it's natural light, whether it's artificial light, whether it's task lighting, the amount of those and how you direct those, or that actually improves healthcare worker, job satisfaction, burnout, et cetera. And it does. That's some of the strongest that we have is actually of evidence-based design literature is actually on the effect of healthcare workers. And so I absolutely think aesthetics matter here. And like I said before, there are very, tried and true principles of design, things like color theory, that actually do come into place. And I think hospitals actually at this point, we're at the point where we really do need to start using this more. It's a fine line, and I think it's a topic that has really interested me as well too, because at one point you can say, do you need the beautiful aesthetic room and the beautiful aesthetic space to perform good patient care? Well, maybe not to actually perform the actual task you're doing, but the overall reality is there's a lot more than just the healthcare that you're performing for the patient. There's things like dignity, and I think, patient dignity and healthcare worker dignity are absolutely affected by giving them a space that is aesthetically pleasing and is comforting to work in. Being able to orient yourself to times of day, with windows and spaces for breaks and spaces for quiet time, in different levels of lighting, absolutely has been shown to affect, healthcare worker burnout and job satisfaction. And the reality is, there's a lot more than just the physical medicine we do. We also treat our patients, and we also, more holistically, we have the families involved, and we have our healthcare workers to think about. And so, to be honest with you, I think this is one of the things that design can absolutely bring in, and I think we're starting to see more and more of that. And I think if we take the principles that we really are giving dignity back to patients and families and healthcare workers, then I think that really is kind of the guiding principle that will kind of help fuel this drive here.
Mm-hmm. Well, let's talk about design thinking for technology, because I know you worked on this dashboard for Code Blue, that you get more information and you're able to show more information over time. So you can improve the quality of your Code Blues moving forward. So how does design thinking, play with technology as opposed to just, physical solutions?
Absolutely. Thanks for bringing this up. So, this, was one of the first big forays I had into, and actually the design thinking process, was a project that we did that we ultimately called, recess visualization. And it came from starting with, as you were talking about before, recent evidence. And so, if we think about performing cardiopulmonary resuscitation, and I'm going to speak specifically to PALS, the pediatric resuscitation, the guidelines will tell you to do what? They will tell you to push hard, 1/3 the anterior posterior diameter of the chest. They'll tell you to push fast. They'll tell you to switch rotators. They will tell you to, allow complete chest recoil every single time. That is how you measure the quality of your CPR. But the reality is everything that I said there was completely provider-centric, meaning it was only focusing on what the providers did, and it does not rely at all on how the patient's actually responding. So in the last 10 years or so, a lot of the resuscitation literature has started to focus on, should we focus on patient goals of cardiopulmonary resuscitation? And what we say by patient goals is, yes, we know how fast in theory we should push on the chest, but really ultimately by pushing hard and fast, is that giving us a blood pressure? Is that giving us a chance, to be able to have an end tidal CO2, which is telling us that we have enough cardiac output of blood going to the lungs to actually create an end tidal CO2? Can we actually feel a pulse during our chest compression? So more patient physiologic response ways to establish our CPR. And so when we had this from the literature saying we should be focusing on targeted physiologic goals for performing cardiopulmonary resuscitation. And so then one of my other roles is I lead the cardiopulmonary arrest review team, meaning we look at the quality of our CPR we perform on every code that happens in the ICU, and we look to see what were the ones we did well, what were the ones we didn't perform well, and what were the outcomes. And when we started looking at this, we have a lot of ways. We have our defibrillators will give us feedback now on how hard we pushed, how fast we pushed, were we meeting all of our target goals there. But it's harder to assess how the actual patient was reacting to it in retrospective time. And so it was with this that we questioned, how might we build a data visualization system that will actually allow us to correlate both provider-centric, meaning how fast, how hard did we push, and patient physiologic response to our resuscitation efforts in order to help understand our resuscitation quality. And so that was our how might we statement after we kind of talked to this was a small group of people who lead the cardiac arrest review team that we're really kind of asking these questions to. And then we worked with computer scientists at the University of Toronto and computer programmers to figure out, is there a way to actually do this? And what we ultimately did is we figured out a way to pull all the waveforms into one specific application that over time showed, during the arrest, when we did a compression this deep and we had whether or not we were meeting the goals, what the patient's physiologic response was. And it really gave a whole new insight into how potentially we could assess the quality of our CPR. Now, this was all retrospective. We haven't gotten into the prospective, and that would be the ultimate goal, would be to use this in real time. But the initial idea was to see if we could do this retrospective. The big thing that we had is these reviews are done with the entire ICU unit in a monthly meeting. And so we had our low fidelity prototype, we tried it, and we put it out for the group. And we did it really, really early, probably a month or two into it. And what we asked for was just as much feedback as we could. We gave people like a survey monkey. Did you like it? Did you not? Did you explain it? Did you not? And we asked very specific questions about every portion of it, and then had them give them feedback. And we did this on an iterative basis, every month. And it took us about 6-7 months before we had a prototype that we actually really, really liked. And at that point, then, what we are starting to work on now is testing with people that are not within our group. And so people at other institutions, we've given this app to get their feedback and to get their testing on it. The next step ultimately will be to, with hopefully some grant funding in the near future, we'll be able to kind of hardwire this and make this a more automated process. Because if we can do it retrospective, then the next step would be to try to do prospective, as I said. And so I think that's a good example, we've talked about, you can do this for physical space, but you also really can do it for processes, right? We have this evidence. We know what the literature is telling us we should be using as our goals for CPR. it's really hard to understand if we're meeting those goals. And so how can we correlate the current data that we have with also this physiologic response, a meaningful way to drive conversation? And that's what we did.
So I'm wondering if you encountered any pushback as a result of anxiety around surveillance, because people often are skeptical. Because when you ask the question, what's the way to ensure that what we are doing is actually hitting the right goals? Oftentimes the answer that the design person always gives is more surveillance. Let's collect more data. And the problem with surveillance is that people are skeptical of surveillance because there's a potential for instance, legal liability. There's potential for decreased autonomy. If I did this thing my way and the way I want it, now you're surveilling me, I have to do it in a more standardized way. And there are not just surveillance, but there are lots of, potential complications from technology. You talk about, loss of jobs, increased work for staff. If I have to do more work to collect more data, I have to review more things. And I think that at the end of the day, this goes down to when you're talking of empathy. Empathy must be holistic for every stakeholder in the pathway, not just the patient, but everyone. So I'm wondering if you encountered any pushback from anxiety around technology like this.
It's interesting. We have, it's not even just technology. There's, we've used design thinking process to look at, how we change some of our practices, things like doing, open chest CPR. And there has been some anxiety with it, coming into terms of, because really we are talking about change. We are talking about innovation. We're talking about new ideas. And I think change in general will always sometimes show some level of anxiety, right? It's a human nature. I think the way that we really try to reframe this is through the idea of engagement and through the idea of, this is a co-design process. This is a process that we really are trying to engage end stakeholders and end users. And that really is anyone affected by it. And oftentimes it's the healthcare workers that are the ones that are anxious about the change. So what we try to do from the very beginning is frame this whole thing as the idea this really is an opportunity to have a voice and to have say into how this works. And that is going to require data, that is going to require getting feedback, that is going to require change. But we're very upfront with, these are prototypes, these are solutions. We want to see what you think, and we want feedback on it. And when you bring it from and we try to say, we are trying to get your opinion and your engagement in how we do this process to make it better. From that standpoint, once you have the engagement, then I think the anxiety around being surveyed, the questions that are coming back and stuff, I think that looks different. It is reframed in the idea of really trying to obtain feedback on something that, especially at a local level, that most of this I'm talking about. Most of the design work I do is in my own unit and at a very local level. It is, what we've really found is, and most of the feedback that we've gotten is, because we'll ask in general after we do these kind of design workshops, that most of these have come through design workshops, by and large, most of them will say, it is really nice to know I have a voice. It's nice to know someone cares. It's nice to know that people are listening to what we think should happen. And so we've actually, on the contrary, had a lot of really, really resounding success and nice feedback with the projects that we've done so far, because we really are asking, we're not coming in with solutions. I never started a design workshop with, this is what I think we should do. I started with, this is the problem that came up. And we start with, co-designing together. And I think the more engagement you have, I think that is the way you're able to alleviate some of that anxiety and that stress. I don't know if that answers your question, but that's the approach that we take is an engagement approach.
So make people feel it's a bit more invested in what they're doing, like they're part of a larger story rather than, a lot of times people feel antagonistic towards change and towards someone they see as trying to impose change on them. If they're part of the story, it makes a difference.
Absolutely. The key thing is, is kind of end user engagement in the actual process. I mean, this, it's like I said, it's human-centered, it's creative mindset, and it really involves co-design, and it involves, designing with the people you're designing for.
I still have this card, by the way.
You do?
Yeah. I think it's amazing how, design thinking can apply to very, very big projects, like building a new ICU or, technological projects. So just a simple, a card to tell you what to do in the case of an emergency. Just a card you have in your pocket. And all of that is design thinking. So it has a wide breadth of application. And I think that's very interesting. And I wonder, two questions, does design thinking, do you use your design thinking to do any research, let's say qualitative research? Because when you talk about speaking to people, you talk to them all the time, ask them for feedback. That's, in a sense, has a research element to it. Do you do research with that?
Absolutely, absolutely, and that's a great question to clarify. There are specific, within the end user interviews and the empathy gathering, you're absolutely correct. This is using mainly qualitative research, and so oftentimes it's qualitative methodology. You will do enough end user interviews until you have a saturation of ideas, which, depending on the question you have, will depend on how many you need to do. But we do all this using standard qualitative research methodology most often. As well as there is some that are a bit more quantitative in terms of sometimes when we do the observations, it'll be a little bit more quantitative in how we obtain the actual data for what we think we are showing there. The other thing too is oftentimes the way you are testing these usually is actually done through QI methodology, because you know what your problem is, you know what you walked in and what wasn't working. So that sort of becomes your baseline and your run chart. You will once you have a prototype that's gone through enough iterations of something you want to implement, then you oftentimes will actually test it for a longer period of time through QI quality improvement methodology. And so there is a scientific basis for how you can do this. That being said, there's nothing that says from the design thinking method that you have to do it. This is something that I choose to do, being an academic clinician. And I think the more that we can put the data behind it, we can show that there is a somewhat scientific way of looking at design thinking. I think that's actually one of the ways you get this more and more uptake within the world of healthcare.
I think that the primary difference, if you ask me, might be the speed. Because qualitative research, you take a long time. But if you're trying to implement changes, oftentimes you have to do something fast, fail fast, try something new, fail again, try something new. And so that speed of change, it might just be the differentiating factor.
I think so. I think that's very, very fair. Oftentimes the way we've been able to kind of circumvent this is most of our quick testing that we do happens within workshops. And so what we will do is we will engage end users into designing a prototype, the next day, and we do these oftentimes through our nursing education days or our ICU education days, where, one group will design, maybe one or two groups will design the prototypes. The next two groups that come through the next day will work on testing it. The next ones will go back to re-prototyping, right? And so we have multiple people engaging within these projects. But then ultimately, once we have something we think we are actually going to do, then we put it through and actually do, a true QI methodology and test it once we implement it. But these are all very small scale changes. Most of the work that I do, like I said, is within, is really driving, solutions and change within our local level here. There are people that are doing this on much broader scales, looking for larger solutions and innovation. And maybe at some point I'll foray there. But right now, my kind of number one goal is to really see if we can develop, a design thinking program that can just become second nature, within our organization.
Yeah, I like the word second nature, because that's my next question. How would physicians or medical students, if they want to incorporate a more design thinking approach to your work that they do every day, what would the process look like?
I think this is fan. I love this question. So, I finally, when I went through medical school, and I promise it wasn't that long ago. Don't let my appearance, fool you. It wasn't that long ago. No one was talking about design thinking. No one was talking about this at all within healthcare. And in the last, couple of years, 5 years maybe or so, it's become part of it. Healthcare's finally caught up a bit. The really unique part, healthcare, by and large, is widely regarded as the most complicated true system within the world, in all honesty. And it just is, if you look at it, broadly across the globe and look how many factors go into it. And so the really unique part, and we often talk about this, in some of my graduate studies, if you are just a designer or coming from outside the system, how much do you need to know to actually improve change, right? And that's a hard question to ask. I think if you flip this around, though, I think people within medicine, healthcare workers, nurses, physicians, medical students, you have a very unique approach, because you are coming both if you have a skill set of a designer, you're coming with a design skill set, but you're also an insider within the system. So you are able to be a designer coming up with innovative solutions, but also being an end user. And I think that's very, very unique. Not all designers are going to be able to do that. And I think you have a whole new understanding of empathy if you are able to do that. So I think it is absolutely needed. And I think it is, if we are going to change the way we perform healthcare and push us forward, then I actually think we need to absolutely train, medical students how to do this. I think the methodology is not hard, right? I mean, I gave a brief overview, and there's a lot of really nice books and stuffs on this. But the other important thing is design is not necessarily linear. I tried to show that you keep going back, you keep rotating back. It is meant to diverge as many ideas and bring in innovation. And I think anyone can do that. I also think from a design standpoint, in all reality, we're asking questions on how do you do this in your job? How might you implement this? How could you make this better? And the really, really nice thing about this is it's very easy to get user engagement because everyone, you're drawing on their lived experience. And whether it is the family experience, interviewing family members, whether it's healthcare workers for, how do you want to redesign your physical space? Should the bed be over here? Can you carry the vent? How many people, how do you transport a patient? Any question like that, you're relying on a lived experience. And so by having, that techniques to actually do empathetic interviews, to question broadly, to really get not just the specific process, but the emotion, the reaction to it, which really is kind of the human-centered portion of that. I think these are things that we learn naturally in medicine, right? Like when you go through your year 1, year 2, when you're learning how to take patient histories, you learn empathy, right? You learn to really listen and convey, not only what they're saying, but how they're conveying non-verbally to you. And you learn those skills. These are the exact same skills that we use. We're just applying them in a different way. And so I think physicians, I think nurses, I think respiratory therapists are keenly able to do, I think they're in a very unique position to be able to do this because we're relying on skills that actually you already have through your professional training. You're just applying it to different things.
So how did you come to do what you do? I know you said you wanted to be an architect. So how did you eventually come to do the architecture of medical design?
Yeah, for sure. So I did. It's true. I always really, really wanted to be an architect. I had a hard time decide between architecture and medicine, and ultimately medicine won out. That was after doing some job shadowing with architects and realizing that it was a lot more behind the desk and a lot not necessarily as human forward that I saw, at least the architecture too I saw. So I convinced myself maybe I could design my own house or something like that and made it into medicine. Ultimately, as I was kind of walking through and working on different academic projects, and I have, a decent research portfolio in the past, but I realized the things that really got me going actually were the small little tasks that were more QI and quality improvement focused. And when I was working more on those, there's a subset, and kind of a new science coming through called human factors. And it really is looking at, what are the human qualities and human innate tendencies that affect our workplace and our workflow. And oftentimes this focuses in with ergonomics, and how do you build a space, and build a chair, build anything to fit a human better. And when I started reading about that, I realized, I was interested in architecture, not just solely for the aesthetics, but really looking at the functional aspects of it, and this came through, if I'm bringing up resuscitation again, we were at my previous institution I was at, it was a large ICU that was built mainly in pods, but there were a couple small hallways off that. And there was one time during a code that going to get the defibrillator, we realized was really, really far. And I started questioning, how many defibrillators do you need? How far should a defibrillator be from a patient? Does it actually matter? Maybe it doesn't matter. And so it was through all of that the idea of evidence-based design came in. And I think when I added evidence-based design and then human factors and ergonomics into this, the questions just kept emerging when I realized what I was really trying to do were solve problems and implement them. I think the way and the key thing that we're missing here is a design focus. We know from a research standpoint, oftentimes what the evidence shows, QI will get us so far, but it's really hard sometimes to actually fully drive sustainable change and implement it. And I realized that I think the big thing we're missing is we're not picking things people actually want to do, and that's because we're not actually empathizing with people in the first place to figure out what the problem is. And so it was through a lot of Googling and a lot of research and understanding this, and I realized this whole idea of design thinking came into play. That the tech industry has been using this for decades, and healthcare is finally catching up. And so I kind of jumped on the bandwagon.
So what does your day-to-day look like then?
Yeah, it's great. So, I mean, my day can be very varied depending on whether I'm on service or not. So if I'm clinically on service, meaning I'm actually caring for patients that week, then it is I'm in the ICU the entire time. I take some time in clinic as well too, and so that'll look different. But if I'm not on service, then it's all my own academic time, my own academic work. And so a lot of that's committee involvement of things I'm on. So the resuscitation committee, I lead the informatics for the ICU. So it's doing a lot, which I could talk forever on redesigning the EMR. That's a lot of the stuff that we work on as well too, in a place that is very design friendly, to be honest, that field. And then ultimately what we often do, you kind of ask, and it's probably a good question to say, how do you come up with new problems that you want to use design for, and oftentimes these come out of a lot of our quality improvement initiatives and a lot of our reviews processes that we do. So for instance, we do a very extensive morbidity and mortality reviews within our ICU. These happen every 3 to 4 weeks. Every patient that dies, it gets reviewed, and every patient that has an outcome that we're not happy with, we do an extensive review of that. And oftentimes, or we do also do our every patient who arrests, we do our resuscitation review. Every patient who goes on ECMO, we do an ECMO review. And it's really oftentimes through these when, as a group, we decide we have an action item, we need to try to change it. It's oftentimes that this is where design comes in. And so do I think design is going to solve every problem? Absolutely not. Sometimes we just make the wrong decision, right? But I do think a designer should be at the table. And I think it should be there to consider whether or not there's a potential design solution for it. And so this is what we've worked on implementing more within our ICU. So this is how things like doing the open chest CPR project came up. This is how things like doing the resuscitation review came up. As well. It was all because of questions and action items that came out of our monthly reviews that we do.
All right. This has been really, really educating. You're a very interesting person to talk to, and a very interesting niche that you occupy. It's not a lot of people who are doing what you're doing. I wonder if you have any other things you want to say or any questions you want to ask.
No, I just want to say I think this is I could not be more excited that, to be honest, we're seeing this more and more at the very beginning of medical training and within medical education. Like I said before, I think a lot of the skills we learn in medical school, we learn how to apply it to patients, and what we really are doing is talking about applying these skills to our system and into our healthcare workers, into our families, into driving more sustainable and innovative solutions. And I think, I could not be more excited that we're starting to see this, within becoming a practice. My dream would be, in 10, 20 years, this is this is how we do it. I mean, design thinking, this is not, these are not hard concepts. I think what we're talking about are ways to systematically drive innovation, that it really has been at the basis of healthcare. And it's been, we're just finally catching up more, and we're trying to figure out a way to systematically do this faster. And so that's sort of where my passion is. That's sort of where, and I think it's really exciting time within medicine that we're doing this. And so I think, things like you're doing right now, asking questions and getting the word out for this as well. I think this is how we start making change like this. So I want to, kudos to you for all of your efforts as well too, to drive innovation as well.
Thanks for taking the time to talk to me. I know you're a very busy person and you're always busy. So I really appreciate you talking to me.
Absolutely. Thanks so much.
All right. So that's it. Is there anything